More than skin deep, psoriasis in people of color. Welcome to Clinical Minute. Kimberly is a 32-year-old U.S.-born black woman who presents at your family practice for her annual well-woman visit. She tells you she would like to get pregnant in the next year. She also has a 4-year history of worsening itching all over her head and increasingly large white flakes shedding from her scalp. She maintains her thick, tight-coiled hair in a long, natural state and is not currently using any chemical straighteners. She tells you she has struggled with dry scalp and facial acne since age 12. She has tried numerous over-the-counter shampoos and natural products with minimal success. Regular salon application of hair straightening chemicals during adolescence caused burns and sores. By age 28, Kimberly noticed a return of scaly, raised, patchy, round lesions on her thigh, similar to lesions she experienced in adolescence. A clinical exam reveals erythematous plaques with silver scales on her scalp, as well as areas of thick, scaly plaques extending beyond her hairline, creating asymmetric plaques on her forehead and glabella. She also has erythematous plaques with silvery micaceous flaking scales on both thighs. You know that psoriasis is a chronic, relapsing, and remitting inflammatory skin disease. Lesions are typically distributed symmetrically on the scalp, elbows, knees, lumbosacral area, and sometimes in the body folds. The exact etiology of psoriasis remains unclear, although there is evidence for genetic susceptibility and immune dysfunction. Psoriasis can also be provoked by external and internal triggers, including mild trauma, smoking, sunburn, infections, systemic drugs, and stress. You know that helping patients reduce or eliminate these potential triggers can help reduce flares. You are aware that psoriasis is associated with physical, emotional, and social burdens, and quality of life may be significantly impaired. Treatment is based on symptom control. You know that racial and ethnic disparities in access to a dermatologist have been reported in the U.S., and the likelihood of having undiagnosed psoriasis was higher among African Americans in a national study. You also know that in darker skin types, psoriasis might have overlapping features with other papulosquamous disorders, thus presenting diagnostic challenges. You remember that key nuances in the clinical presentation of psoriasis in skin of color include less conspicuous erythema, whereby skin may appear violaceous or hyperpigmented, post-inflammatory hypo or hyperpigmentation, potential for increased body surface area or BSA involvement at initial presentation relative to white skin. In most cases, a dermatologist or primary care physician can diagnose psoriasis clinically by examining the skin. It is important to obtain a thorough medical history and determine if there is a family history of psoriasis. Sometimes taking a small skin sample for biopsy may be indicated to confirm the psoriasis diagnosis and rule out other disorders. You know that there are 3 treatment categories: topical medications, phototherapy, and systemic medications, which may be oral or injectable biologic systemic medications. You know that it is important to discuss pregnancy plans with patients of childbearing potential, as several treatments are contraindicated during pregnancy. Since Kimberly's pregnancy is planned, you are able to plan for treatments that will be safe during pregnancy. You know that topical corticosteroids are the cornerstone of psoriasis treatment, and that they may be used intermittently or long-term. Lower potency corticosteroids may be used safely on the face or areas with thin skin. Mid or high potency corticosteroids may be prescribed as initial therapy on other areas of the body and for thick, chronic plaques. With all corticosteroid strengths, intermittent breaks should be taken after an initial treatment burst to minimize the risk of adverse effects. Taking steroid breaks on weekends and using an alternate topical agent on weekend days instead is one option. Topical corticosteroids have a pregnancy category C risk. Women who are pregnant or actively trying to conceive should be counseled about the risks and benefits of these agents. Steroids are generally considered to be safe in pregnancy, however. Local adverse events include skin atrophy, telangiectasia, stria, purpura, contact dermatitis, and rosacea. An important systemic adverse event to be aware of is hypothalamic pituitary adrenal axis suppression, with long-term use of mid- and high-potency corticosteroids. Class 1 corticosteroids should be limited to 2 to 4 weeks of continuous use. They are safe to use long-term as long as breaks are taken. You know that most traditional systemic medications require discontinuation before trying to conceive. Methotrexate is pregnancy category X. It should be discontinued at least 12 weeks before attempting conception. Retinoids such as tazarotene, azitretin, and isotretinoin have been linked to birth defects and should also be discontinued before trying to conceive. Women of childbearing age who take azitretin must use reliable methods of birth control during treatment and wait 3 years after discontinuing the medication to become pregnant. Women must also receive verbal and written warnings about pregnancy avoidance during isotretinoin therapy and for 2 months following treatment discontinuation. Biologics are typically implemented when one or more traditional systemic agents fail, are poorly tolerated, or are contraindicated, such as during pregnancy. Most FDA-approved biologic medications for psoriasis fall into pregnancy category B. Animal reproductive studies have failed to demonstrate a risk to the fetus, and there are no adequate and well-controlled studies in pregnant women. Phototherapy for psoriasis is safe for use during pregnancy. However, PUVA photochemotherapy falls in pregnancy category X. Studies in animals or humans have demonstrated fetal abnormalities, and the potential risk to the fetus outweighs the potential benefit in pregnant women. You tell Kimberly that she has scalp psoriasis and plaque psoriasis. After discussing pregnancy risks, you tell Kimberly you will start her on triamcinolone 0.1% ointment to be applied to affected areas 2 times daily for up to 2 weeks. You will consider starting her on injectable adalimumab if topical therapy alone is insufficient. You know that, if started, her injection regimen would be: Day 1, treatment initiation with an 80 mg dose, which means self-injection with 2 40 mg pens. Day 8, begin every other week dosing with 1 40 mg pen. You also counsel Kimberly on proper scalp and skin care. You tell Kimberly that between 50 and 80% of patients with psoriasis develop lesions on their scalp. You know that presentation can range from slight scaling to thick, crusted plaques covering the entire scalp. You acknowledge that due to the visible nature of scalp psoriasis, it can be a particularly frustrating manifestation of the disease and may cause significant emotional distress. You tell her that her dry or brittle hair, intense itching, and dandruff-like flakes are typical symptoms of scalp psoriasis, and that psoriasis shampoos contain ingredients to soften and loosen the scales of scalp psoriasis so they can be washed away. 2 main types of psoriasis shampoo are coal tar shampoo and medicated shampoo. The active ingredient in the latter may be a corticosteroid or salicylic acid. You know that particularly for African American women with scalp psoriasis, the impact of hair texture, styling practices, washing frequency, and cultural preferences impact treatment. You tell Kimberly that chemicals in hair dyes and perms can sometimes irritate and worsen scalp psoriasis or even cause an allergic reaction. You tell her that many of your African American patients prefer steroid oils. You counsel Kimberly to apply fluocinolone scalp oil at bedtime twice daily and to decrease frequency as her psoriasis improves. Using steroid oil overnight prior to washing will help soften and loosen scales. She should shampoo her hair as frequently as she feels necessary, using a gentle fingertip massage to loosen the scales. Ointments, creams, or lotions are typically avoided in scalp psoriasis, but may be used if she prefers. You also counsel Kimberly on the importance of moisturizing her skin all over at least twice daily. She should use ceramide-based moisturizers after applying topical medications to improve penetration and efficacy. You recommend applying medications and moisturizing within 1 to 2 minutes after bathing to lock in moisture. You recommend using skin cleansers formulated for sensitive skin, avoiding excessive cleansing and antibacterial and fragranced products. You ask Kimberly to schedule an appointment in 3 months for follow-up. When Kimberly returns, she tells you she is pregnant. You know that while more than 100,000 births are estimated to occur annually in women with psoriasis, the course of psoriasis during pregnancy is unpredictable and variable. The uncontrolled inflammation and excess cytokines inherent in psoriasis can influence the course of pregnancy. Approximately 50% of women experience a clinical remission of their psoriasis during pregnancy. Other women may have worsening or experience no change. Hormonal changes in pregnancy may play a role in improving psoriasis by promoting a state of immune tolerance. A literature review determined that almost half of the included studies detected an association between psoriasis and an adverse pregnancy outcome in women with psoriasis. Outcomes included spontaneous abortion, cesarean delivery, low birth weight, macrosomia, large for gestational age, and composite outcome of prematurity. You educate Kimberly on the risks of pregnancy with psoriasis and tell her that you will collaborate with her obstetrician to optimize her chances of healthy pregnancy and birth outcomes. You review the psoriasis treatment in pregnancy algorithm with her obstetrician. Topical treatments, including emollients and low to mid-potency steroids, are considered safe during pregnancy. Higher potency steroids could be considered next, but should be reserved for second or third trimesters if possible. Narrowband UVB or broadband UVB is recommended as second-line therapy when topical therapy fails. Counsel patients that phototherapy may result in increased pigmentation in exposed areas. Cyclosporine and TNF-A inhibitors may be considered as alternative approaches with close medical monitoring. It is preferable to avoid systemic medications during the first trimester. You also review the safety of psoriasis medications in lactation with Kimberly's obstetrician. You note that safety data for lactation for some medications used for psoriasis are limited. When treatment is required, consider only topical corticosteroids for lactating women. You know that 40 to 90% of patients experience worsening of psoriatic symptoms in the postpartum period. Since some obstetricians may not be aware of the possibility of psoriasis flares, it is very important for the physician managing the patient's psoriasis to discuss the treatment plan with the patient and her obstetrician prior to delivery. You know that pregnancy registries track women taking drug therapy during pregnancy. You ask Kimberly for her consent to enroll her in the registry for pregnant psoriasis patients or those considering pregnancy. You counsel Kimberly to only use the topical treatments on her skin and scalp during pregnancy. If these prove ineffective, you will consider phototherapy. If phototherapy does not work, you will consider safe systemic medication. Kimberly returns for her follow-up visit with her healthy baby girl. She experienced a healthy term pregnancy, affected by gestational hypertension without severe features. You tell Kimberly that she may experience worsening of her psoriatic symptoms postpartum, and that you will continue to monitor her closely and adjust her treatment plan if her disease flares.